Everybody. Thank you so much for joining us for our discussion about trauma-informed CL psychiatry. I'm Nona Nichols, and I'm joined by my esteemed colleagues to discuss this. So just to give you kind of an idea of where we're going, so I will start with an introduction to trauma-informed care, just kind of the 101. I'll be followed by Dr. Spada, who's going to discuss ACEs and how those impact people throughout the lifespan. Dr. Sachdeva will follow with a discussion about trauma in women, including sexual trauma and IPV. Dr. Fonseca will be here discussing minority stress and trauma, and then Dr. Dragonetti will finish us off with medical trauma and PTSD in the general hospital. And then this is our DEI statement. So we thought this was really important just for everybody to know. One of SAMHSA's 6 informed principles is this consideration of the cultural, historical, and gender issues. So we thought that our topic naturally was like very fitting in that way. And the goal is for you to feel comfortable providing trauma-informed care and also to be comfortable talking with your colleagues about it in other disciplines. So let's go ahead and get started. The intro, I have no disclosures. So I want you guys to be familiar with the scope of trauma. We'll discuss concepts related to trauma-informed care, particularly as they relate to PTSD and acute stress disorder, and then we'll finish off with a case. So I'd like to start us off with just looking at how very prevalent trauma is worldwide. So the World Health Organization World Mental Health Surveys, which are based off of information from the 30 countries that you can see in various states of highlighting with little arrows representing all regions of the world with a total sample size of 166,000. When they did these surveys, they found that over 70% of the respondents had had at least one lifetime trauma. In the US, it was actually pretty high, which you can see kind of compared to the other countries. And then the rate of exposure to any trauma is interesting, though, because it's 321 per 100 respondents, which tells you that a lot of these people aren't just having one event, they're having many. So within the United States, this epidemiological survey from a 2012 to 2013 data that's 36,000 adults, we get some other prevalences. So lifetime prevalence of PTSD is 6%. Women are twice as likely to develop PTSD throughout their lives. And then 5% of the population has an active PTSD diagnosis at any time. Some other key takeaways from this are that there are certain individuals that are more likely to have this diagnosis. So this particular study found that the PTSD diagnosis was more prevalent in the Native American population, individuals younger than 65, people who had been previously married, and then people that had less than a high school education and lower socioeconomic status. The other thing is that they found increased risk of mood disorders and substance use disorders with the PTSD diagnosis, which is what this chart's showing. And basically it shows that after adjusting for socio-demographic and diagnostic covariates, there are associations with all of the listed substance use disorders, mood anxiety, and personality disorders. Strongest in general was for any mood disorder, then borderline personality disorder, schizotypal disorder, and then notably also in bipolar 1, the association's particularly strong. The other statistic that was really interesting from this paper is this 4.5-year lag from the onset of PTSD to treatment, which means that a lot of these people are experiencing a pretty significant delay in getting care. So let's talk a little bit about some risk factors for the development of PTSD, which are broken up in terms of the pre-traumatic, peri-traumatic, and then post-traumatic. So we already discussed a few of these, but interestingly, so while men are more likely to be exposed to trauma by report, women are more likely to have PTSD, which is suspected to be due to sexual trauma, which Dr. Sachdeva will talk about. The other thing we talked about age. Education is seen as kind of a stand-in for IQ, and it's been shown in general and is believed that people with like lower IQ does make you more likely to develop PTSD as well. The data on race is varied, but what we do know is that minorities are more likely to have and develop PTSD. Also, minority sexual orientations are more likely to develop PTSD. In terms of pre-trauma psychopathology, they've shown that problematic externalizing behaviors in children and anxiety are both associated with a greater likelihood of PTSD. Prior trauma, so kind of thinking ACEs and all the cumulative trauma that people go through. And then we also know that family psychiatric history does play a role, as well as neurobiological factors. So then moving into the peri-traumatic, so trauma type, so the highest PTSD risk is going to be with people that have violent, oops, sorry guys, I just clicked that incorrectly. So highest risk is going to be with people that have violent crimes with physical injury or sexual assault, and then the continued perception of threat as well. So obviously the longer that people feel endangered, the more likely they are to develop PTSD. And then moving into the post-traumatic. So to make sure that this isn't too confusing, I noted that these are actually protective factors. So these are protecting against PTSD. So access to resources, having good social support, physical activity, and then positive altruistic behavior are all protective against developing PTSD. And then the post-traumatic cognition, like very inflexible kind of thinking patterns are going to be more associated with the development of PTSD. So let's break down some terminology here. So trauma itself is subjective. We're going to use the SAMHSA definition, which is a little bit more broad than the DSM-5 that a lot of us normally think of. So for SAMHSA, trauma results from an event, series, or set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening that has lasting effects on an individual's functioning, mental, physical, social, emotional, or spiritual well-being. And I just want you to kind of hold that definition, and then we'll go into the DSM-5 one. And then trauma-informed, the important part here, I'm not going to read all this to you, but basically it's a system-wide way of thinking. So you're practicing with the patients and then with everybody in the system as well. The best way really to think about providing trauma-informed care is to change the question from what's wrong with you, what's wrong with a patient, to what happened to you, and really tap into that empathy and genuine wanting to understand where they are and where they're coming from. All right, so DSM-5. So not all trauma is going to lead to acute stress disorder or PTSD, but to qualify for acute stress disorder or PTSD, it requires exposure to a traumatic event, and this is the direct quote, actual or threatened death, serious injury, or sexual violence through any one of these ways. And you can see that the bar for that is much higher than looking at general what can be caused as trauma through SAMHSA, which we talked about earlier. Right. And then these are, of course, the other criteria: intrusive symptoms, avoidance, negative changes in mood or cognition, and the changes in reactivity or arousal. And of course, we have the time criterion. So next, we'll talk a little bit about SAMHSA's guiding principles for a trauma-informed approach. So first is safety. This is individuals feeling safe in the place where they are, whether this is home, the hospital where they're being treated, the clinic. The next is trustworthiness and transparency. So with this, patients need to be kept in the loop about what's going on when they're making decisions, and the whole goal should be to earn the patient's trust. Then peer support. When available, we want those with the shared experiences to be able to work with our patients. Collaboration, we should always be using shared decision-making. Empowerment, the patient should be validated with their strengths recognized, and resilience really needs to be the focus and the emphasis. And then finally, always considering the cultural, historical, and gender issues. So that is acknowledging and addressing biases, stereotypes, and any history of trauma. So how are we going to do this? We're going to practice the 4 C's. So Calm, contain, care, and cope. So you need to be paying attention to your own feelings as you're caring for your patients and maintain your own calmness going in, as well as being mindful of how the team is doing and helping them to cope and process those feelings as well. Then containing. So you need to meet the patient where they are and be mindful that it is very likely that you will need to limit how much detail they want to provide of the trauma history to maintain their emotional safety, while also giving them resources and aids so that in a safe place, they can then discuss this with other people and get that long-term care that they need. The goal is to just avoid re-traumatization of the patient. And that's through having them relive their history of trauma in great detail, but also making sure that you're providing a safe place in the hospital. Then care. So this is both for you and for the patient, making sure that you're caring for yourself so that you can care for others. The other thing is to make sure that you're normalizing and destigmatizing the trauma symptoms, both to the patient and then also reminding the team as well. And then finally, helping the patient to cope. So we really want to reinforce those resilience and positive coping skills. And then, of course, getting the patient in with the best possible resource that they can that's appropriate. All right. So we'll move into a case. So this is Miss W, and she is a consult that I received. So worsening mood in a 33-year-old G1 P0 postpartum day 4 after a medical termination at 22 weeks for chronic hypertension with superimposed preeclampsia. So she'd been admitted a week before with elevated blood pressure and headache. She went to the ICU, had an nicardipine drip. They got her blood pressure down. She went to a regular nursing floor. Unfortunately, it started shooting up again and again. They couldn't get it down into a safe range. So then they had to start talking about termination of the pregnancy. So the patient was initially offered an induction of labor versus a DNC. She wanted to do the DNC. Unfortunately, because she was at 22 weeks, after much back and forth, during which time this poor patient knows she's going to lose this baby regardless, she finds out she can't actually get the DNC. She has to do the induction of labor instead. She had her induction of labor. The fetus was pre-viable. She was discharged from the hospital. 4 days later, blood pressures are back up due to the preeclampsia. So she gets admitted with hypertensive crisis. Psychiatry was consulted for the depression. By the way, she's on the OB floor again with all deliveries. All right. So you can see multiple places where this poor lady has had a lot of trauma during this stay. So how are we going to apply a trauma-informed care approach? So calming the patient. One of my big concerns was her being on this floor where people are still delivering. She actually was okay with that. But then there was that piece. There was also discussing the patient care team reactions and kind of normalizing her grief, normalizing this anxiety at being back, because it was a very difficult case for everybody that was there. The big goal with the calming was to figure out how could we make this a safe environment for her. Then containing. So we wanted to make sure that the patient actually wanted to talk to us and wanted to tell us about her trauma. And then really following her lead with the discussion throughout and providing her with as much autonomy as we could to avoid the re-traumatization. So the care piece involved a lot of normalization of the patient's reaction and distress, as well as really helping her through a lot of the feelings of guilt that she was struggling with. And finally, coping. We talked about those resilience factors. We discussed family, friends for support, provided information about loss and therapy, group information, and then discuss like these would be the signs or symptoms that you have depression, anxiety, PTSD that need to be treated, but letting her know that her reaction was very normal. Great, these are my references. And with that, I will give you to Dr. Spada.
Okay. Hi, everybody. I'm here to talk about adverse childhood experiences today. So I don't have any disclosures. I do have one disclosure, and that's just that we could have like a week-long conference on adverse childhood experiences. And so I'm trying to hit the high points in 15 minutes. And I'll do my best with that. So our objectives for today are to define adverse childhood experiences and to identify the impact of them on social, medical, psychiatric, and obstetric outcomes across the lifespan. We're going to delve into some of the studies on disparities in ACEs and concepts around that. And then we'll discuss key strategies for prevention of ACEs and the concept of benevolent childhood experiences, which is my favorite part. All right, so we'll tackle objective 1 first. And in order to do that, we're going to take a look at a case that I had, which I think really illustrates some of these concepts and how they play out in clinical care. So we have the case of Ms. A. She's a 22-year-old G1, now P1 at 37 weeks. She was admitted for an induction of labor in the setting of preeclampsia, and she has had a vaginal delivery. When I went to see her, she told me that her mood has been up and down. And she disclosed a trauma history and trauma-related symptoms that were really consistent with PTSD. She doesn't have active IPV, that's important to know, but she had a history of it. She stopped her lamotrigine when she found out she was pregnant, but she said it wasn't really helpful for her in the first place. And an alarm went off in my head when she said she wanted to do things differently than how she was raised. And this is something that we hear pretty frequently in the obstetric setting. So in terms of her past psych history, at age 16, she said she took sertraline intermittently and only at a dose of 25 milligrams because her parents weren't supportive of her seeking treatment. She had 1 hospitalization for suicidal ideation 2 years ago, and she was engaged with therapy at the beginning of pregnancy, but she stopped because it was hard to get to. And because of that alarm that went off in my head, I asked her to tell me a little bit about her childhood, and the floodgates opened when that discussion happened. So she said her father had a history of alcoholism and he was in early remission. So he was recently back in her life, which had brought about a lot of complicated feelings for her, both positive and negative. He had been diagnosed in the past with bipolar disorder. In his states of intoxication when she was younger, she experienced emotional abuse from him. And there was IPV in the home growing up from dad to her mother. Mother did file for a divorce and filed for protection from abuse against her dad when she was 7, but there was still significant chaos in our home even after that. So when we talk about ACEs, we're going to have to talk about the landmark study by Fletty and colleagues. And we'll do that in a moment. But their study looked at adverse childhood experiences, including psychological abuse, physical abuse, sexual abuse, and then household dysfunction. And so you'll see those listed here. Those included violence against mom, so like IPV in the home, divorce and separation of parents, substance misuse in the home, a relative with mental illness in the home, or a relative in the home who had been incarcerated. And when we think about Ms. A, she's packed with ACEs. So she experienced psychological abuse growing up. There was violence against her mom in the home. Her parents separated, and she had a parent with substance misuse and mental illness. So she met 5 of these categories. And when we look at the study, the questions from the original study, I'm not going to read them out here, but here they are, including household dysfunction, physical abuse, psychological abuse, and sexual abuse. So there were 11 questions. And when we look at that landmark study specifically, it was a joint study between Kaiser Permanente and the CDC, and they touched a lot of people. So they emailed the ACEs questionnaire to just over 13,000 adults. They had a 70% response rate, so just under 10,000 people responded to the questionnaire. And 66% of them had reported at least 1 ACE. So we know ACEs are really common. And more than 20% of people reported 3 or more. And their key finding or key takeaway that I want to highlight is that there was a graded relationship between the number of categories of exposure between, so number of ACEs, and each adult health risk behavior they studied. And so things got really serious when people had 4 or more ACEs, and you'll see here there was a stark increase in terms of health risk when people had 4 or more ACEs. So there was like a 4 to 12-fold increased health risk for alcohol use disorder, drug misuse, depression, and suicide attempt history for people who had 4 or more ACEs. 2 to 4-fold increased risk of smoking, poor rated health and a 1.4 to 1.6 fold increased risk in physical inactivity and severe obesity. All right. So they also talked about ACEs affecting multiple levels, and I love this triangle here that they included in their article with adverse childhood experiences at the bottom, and you see how each category goes up. So there's when someone experiences adverse childhood ACEs, they will have disrupted neurodevelopment, which can lead to social, emotional, and cognitive impairment, an adoption of health risk behaviors leading to disease, disability, and social problems, and culminating in early death. And I also just want to make note, just as adverse childhood experiences have effects across the lifespan that culminate in increased morbidity and earlier death, they also can have effects across generations. And so that's why Ms. A's comments were so salient, that she wants to do things differently. Okay, what about ACEs and perinatal outcomes? There's going to be more discussion about this later on, but I just want to highlight, just as there are negative outcomes in social, emotional, physical, and psychiatric later on in life, those with more ACEs have increased risk of negative perinatal outcomes, including increased rates of depression, anxiety, PTSD, tobacco and other substance use, greater rates of intimate partner violence, increased rates of unplanned pregnancy, preterm birth, specifically has been studied with respect to childhood sexual abuse. And then children of parents who have had ACEs are also at risk for poorer outcomes in life. So wanted to talk a little bit about what's out there about disparities in ACEs, because there are some interesting studies. And this study here was a cross-sectional study. Okay. This study here was a cross-sectional study from the 2018 Maryland Youth Risk Behavior Survey that surveyed 40,000 high school students, and they found disparities in terms of race. So the prevalence of having at least one ACE was significantly higher for students who were Black, Latinx, or multiracial. And those students were more likely to report food insecurity. And there were also, it was interesting, they found disparities amongst the most common type of ACE. So Black students were more likely to have a family member who had been incarcerated, while those who identified as white were more likely to identify having mental illness of a family member. And this study was a cross-sectional study of adults from South Carolina. They looked at they surveyed just over 15,000 adults to look at associations among ACEs, race and ethnicity, and healthcare access among adults in South Carolina. And they had some interesting results too. So they found that females, those who were under the age of 35, those who hadn't obtained a college degree, and individuals with a low annual household income, they reported having at least one ACE significantly more than their counterparts. And the prevalence of having at least one ACE was significantly higher among Black adults and Hispanic adults. And those adults were more likely to report having no health insurance, not having a personal doctor, not having checkups in the last 2 years, and having had to delay medical care due to the cost in the past year. So those health-related outcomes and behaviors. And I feel like I can't talk about disparities in ACEs without talking about disparities in sexual abuse. And Dr. Nichols spoke about this, but there is a significant disparity in terms of who is being abused, particularly in childhood. So 1 in 9 girls and 1 in 53 boys. And then 82% of victims who are under the age of 18 are female. And females ages 16 to 19 are 4 times more likely than the general population to be victims of rape, attempted rape, or sexual assault. And you can see here, I find this fact staggering, but 93% of victims of childhood sexual abuse, and 93% of the cases the victim was known the assailant was known to the victim. And 34% of the time, it's a family member, which can have really significant consequences. Okay, so I said we were going to talk about I'm hitting objective 3 now in this whirlwind tour of ACEs. Thank you all for sticking with me. We're going to talk about key strategies to prevent ACEs. And then my favorite part at the end, we'll talk a little bit about benevolent childhood experiences. So the CDC has put out strategies to prevent ACEs. They have this nice toolkit on their website, and they talk about making impacts at more of a structural and societal, taking more of a structural and societal approach. So you'll see here they're talking about taking steps to strengthen economic supports to families and promoting social norms that protect against violence and adversity, steps to take to ensure a strong start for kids, teaching skills to parents and children, connecting youth to caring adults and activities. And we'll talk more about that with benevolent childhood experiences. And then intervening to lessen immediate and long-term harms by doing things like enhancing primary care, having victim-centered services, et cetera. And in their toolkit, they also talk about the importance of raising awareness of ACEs. So I wanted to bring this up here today to raise awareness and change how people think about the causes of ACEs and who could help prevent them. So really shifting the focus from individual responsibility to thinking about community solutions, like we can all be part of the solution. This will also help to reduce stigma around seeking help with parenting challenges, because there is so much stigma around that, and particularly those who struggle with substance misuse, depression, or suicidal thoughts. So in order to promote safe, stable, and nurturing relationships and environments where kids can learn, live, and play. And so I want to conclude by talking about the benevolent childhood experiences scale, which is one of my favorite things to ask patients about with some of these questions. So this has been a validated scale. It's more recent, and you can see there's like 10 positive experiences in childhood, including did you have at least one caregiver with whom you felt safe? Did you have at least one good friend? Did you have a routine, good neighbors? Was there like one adult in your life who cared about you? And in this one particular study, higher levels of these benevolent childhood experiences predicted fewer PTSD symptoms and stressful life events in pregnant women. So we know that these are protective factors. So they're ones that I think are really important when we see patients to ask about. And they looked specifically, this study looked specifically at people who had 4 or more ACEs, because we know that they're the most at risk. And they found that those with 4 or more ACEs who grew up with one adult who made them feel safe and protected were less likely to report frequent mental health distress or poor health compared to their counterparts who didn't have one adult. So I think this has a lot of societal implications when we're thinking about the patients we're seeing and their children. And it sort of gets back to those CDC principles. So now I want to end with Ms. A, just to sort of tie it all together and what we talked about at the end. We acknowledged her history, and we really commended her willingness to seek help and her bravery in talking about these concepts. We started her on an SSRI because she had symptoms of PTSD and depression. We referred to her for behavioral health follow-up, and we really talked about the importance of trauma-focused treatment down the line because she did have PTSD. And we encouraged our home nurse visiting program, so we connected her with social work to talk to her about a home nurse visiting program to help ensure that her child had as healthy of a start as possible, and then also asked social work to just talk to her about any additional resources. So I want to thank you all for listening and going on that whirlwind with me. And I am going to sorry, I'm not meaning to go through your slides, Dr. Sachdeva. I'm going to turn it over to Dr. Sachdeva to talk about trauma in women. Thank you.
Good morning, everyone. I'm here to talk about trauma in women. I have no disclosures. And these are my objectives. So I'll be mainly focusing on sexual trauma and intimate partner violence today, and role of CL psychiatrists when they encounter these situations. So violence against women is a major public health problem. The most common forms are sexual violence and intimate partner violence. So worldwide, about 35% of women have either experienced sexual violence or IPV or both, which is like 1 in 3 women. And there are other forms of violence, which we'll not be talking about today, is forced marriage, female genital mutilation, human trafficking, and military sexual trauma. Just to make you aware, military sexual trauma definition includes both sexual assault and sexual harassment. And as we've already heard, that women, though they tend to experience trauma less as compared to women, they're still twice as likely to develop PTSD. This is mainly driven by the frequency of sexual assault in women, and also the higher propensity that women have for depression and anxiety disorders, which makes them more predisposed to post-traumatic stress. So again, going with case here, since Dr. Spada had Miss A, I have Miss B. So Miss B was found down and brought to ED. She was found to have multiple bruises, a few rib fractures, and vaginal bleeding. As she's being examined, she starts having seizures in the ED, and so she's admitted to the epilepsy monitoring unit. On further investigation, her labs and brain imaging are found to be normal. Her drug screen is positive for opiates, and her pregnancy test is negative. And we were consulted because she was distraught, tearful, fearful, not engaging, and not allowing pelvic exam. And we'll come back to her later in the talk. So going on to the numbers for sexual trauma. So staggering statistics, 1 in 5 women in US experience rape. And just like the childhood sexual abuse, about 80% of these are committed by a person familiar to the victim. And unfortunately, rape is the most underreported crime. I think, as we've already heard, sexual assault is the trauma that's most likely to lead to post-traumatic stress disorder. The populations that are most vulnerable for this unfortunate experience are the physically and mentally disabled, college students, homeless, child abuse survivors, people living in poverty, drug users, sex workers, people living in prisons, and then sexual and ethnic minorities. So numbers for IPV are even more dismal. Studies have found that IPV is common in all countries and all cultures. In US, 1 in 3 women is a survivor of IPV. So probably we all know someone who's going through this or has gone through this. And in addition to the morbidity and mortality associated with IPV, which we'll talk about, the economic cost is staggering as well. So it can be up to $8 billion annually. So the CDC definition of IPV includes these 4 dimensions. So physical violence is the intentional use of physical force, and which can include hitting, slapping, pushing, grabbing, threatening with a weapon. And then sexual violence, of course, is sexual acts without victim's consent. It also includes a sexual act when the victim is unable to consent because of drugs or alcohol or mental incapacity. Psychological aggression includes degradation, humiliation, belittling, coercive control, such as limiting access to transportation, family, friends, or a control of reproductive and sexual health. And please note that this also includes stalking, the definition of IPV, which is a pattern of repeated unwanted attention, like following, spying, leaving gifts, leaving threatening objects. And there are 4 factors which can intersect to increase and cause the increased risk for IPV. So individual risk factors, as we can see, include young age, low education for the perpetrator, and for both the victim and the perpetrator. Witnessing violence as a child increases risk for being a victim of IPV or being a perpetrator of IPV. And then relationship risk factors such as marital discord, negative attitudes towards women, where men think it's okay to solve problems with violence. And then men who have multiple sex partners. Community risk factors in communities where there's high violence prevalence, lack of resources, poverty and unemployment, and social risk factors where we are okay with gender inequality there's cultural acceptance of violence as problem-solving method. There's devaluation of women. There's weak legal sanctions for IPV or lack of civil rights for women. So why do women do not leave violent partners? So there's several reasons, which can include fear of retaliation. One big one is lack of alternative means of economic support, or concern for losing the custody of their children, the stigma of divorce. But one important one is the love that they have for their partner and the hope that the partner will change. So they keep going through this cycle of violence where the abuse or the battering phase is followed by the partner apologizing, bringing gifts, bringing flowers, and promising that this will never happen again. So this is the honeymoon phase. But after the brief honeymoon phase, the tension again builds up and it again results into abuse. So it's important to educate our patients about this cycle of violence, which keeps them tied to these relationships. So consequences of IPV, I will include the consequences of sexual assault in here as well, because there's quite a bit of overlap. So of course, physical injuries, definitely we see lacerations, concussions, fractures. TBI is a big one. About 75% of IPV survivors have one or multiple TBIs. And this physical injuries and abuse can be severe to the point of strangulation. And strangulation is a harbinger of homicide. So IPV is a huge risk, significant risk factor for homicide. About 40% of murders of women are committed by a current or ex-partner. So it's really important for us to intervene. And then many of these women have chronic health conditions such as fibromyalgia, chronic pain syndromes, irritable bowel syndrome, chronic headaches. Sexual and reproductive health repercussions can include chronic pelvic pain, sexually transmitted diseases, unintended pregnancy, traumatic miscarriage, sexual dysfunction. And psychological consequences, of course, are a big one. There's a huge link of IPV with suicide, and these women are 3 times more vulnerable for depression, 4 times for anxiety, and 7 times for post-traumatic stress disorder. There's somatization, and especially tied to history of sexual abuse and sexual assault, or eating disorders, psychogenic seizures, substance use disorders. Then, one thing we cannot ignore is the cost of exposure of children to IPV. These children, of course, they also struggle with depression, anxiety, delinquent behaviors. And, I guess the saddest thing is that this continues the intergenerational transmission of violence, because children who are exposed to IPV are likely to become victims themselves or perpetrators of violence as they grow up. And not to forget the societal cost of IPV in terms of lost productivity. These women are twice as likely to have medical visits, 8 times more likely to mental health visits, which all adds up. Then touching on IPV and pregnancy, so the myth is that pregnancy is protective. Pregnancy is not protective for IPV. In fact, there is potential for escalating frequency and severity, and the prevalence can be as high as 20%. Adverse effects, of course, can, as we can imagine, can include placental abruption, miscarriage, and then there's effects on the growth of the baby with low birth weight, stillbirth, neonatal death. There can be preterm birth, poor engagement in prenatal care, and perinatal mood and anxiety disorders. So again, talking about effect of sexual assault, again, those women may have a hard time engaging in prenatal care. They may be very reluctant to get pelvic exams, which interferes with their care. They have higher incidence of perinatal mood anxiety disorders with all the consequences of PMADs, with difficulty breastfeeding, difficulty bonding with the baby. Since it's so, the prevalence is so high in pregnancy, and then there is increased opportunity for intervention in pregnancy, the ACOG, American College of Obs and Gynae, recommends that all pregnant women be screened for IPV at the first prenatal visit, once per trimester, and postpartum. So let's talk about the screening for IPV and sexual assault. These are the screening recommendations by different organizations. So in 2013, the U.S. Preventive Services Task Force recommended that we screen all reproductive age women for IPV. They did not recommend universal screening because we don't have evidence that the screening reduces the incidence of violence, but we do have evidence that screening identifies victims of IPV, and the interventions that we offer the women do benefit the women. And SAMHSA just wants us to follow trauma-informed model care for all patients, so which we've talked about earlier. So ACOG also recommends that screen all women for sexual assault and for history of childhood sexual abuse. So physician's role, it's mainly the biggest portion is learning and being aware. And then we have to definitely work on identifying these women and responding to disclosures. So let's spend a little time on how do we do the screening. The first point is need to be done in a private setting without the partner there. And if we need professional language interpreters, please do use them to avoid the language barriers. You definitely start with a normalizing statement, such as like, we ask these questions of every patient. This is a routine part of our assessment. So kind of not put her on the spot. And you want to avoid trigger words such as rape, battered, and it's better to say survivor instead of victim. And then before the disclosure happens, you want to discuss the limits of confidentiality. Child protect, in all 50 states, we're required to inform Child Protective Services if we hear that a child is in danger of any kind, including exposure to IPV. And, IPV is a crime in most jurisdictions, but reporting is not mandated. And the reporting choice should be left at the women, because sometimes, many times, it may increase the danger for the women. So leave the choice up to her, but there are some states which require reporting of certain kinds of injuries, such as like injury with a weapon. So know your state laws. And if reporting is required, please let the woman know before disclosure so she can make the choice accordingly. Want to make sure that all staff is trained in this. So once the disclosure is happened, you want to validate the women. It takes a lot of courage to do this. I want to tell them that it's not their fault, they're not to blame, and everybody deserves to live a violence-free life. Next up, you'd really want to make sure the immediate safety of the men and the children, establish a safety plan if necessary. You provide referrals and education. And important to document accurately, because this may become forensic evidence at a later point. So you want to include quotes from the women to document injuries. You may want to use a body chart or pictures if necessary. So there's good screening tools for this. A few of these are listed here, like the abuse assessment screen assesses both sexual and physical violence. HARC is just assesses sexual violence. It's a relatively new tool. And then there's the partner violence screen, and the STAT, which does not assess sexual violence. So HARC and STAT have good sensitivity and specificity. So just these are examples of some screening tools. So just looking at STAT, so it includes 3 questions which ask, like, have you ever been in a relationship where your partner pushed or slapped you, or your partner threatened you with violence, or your partner has thrown, broken, or punched things? Even one positive answer is a positive screen. So I wanted to include this here because this hand sign was started by a Canadian women's foundation, but it's thanks to social media. It's well known across the US, and any of your patients may use this to signal for help. So a hand, a palm, a thumb in the palm with fingers folded over is a help me sign. So that's a quiet signal from the women to need for help. So hopefully you know this and are able to respond. So role of the CL psychiatrist. Of course, we've talked about implement screening. Remember that the recommendation is to screen all reproductive age women. And when we do this, we want to follow the TIC principles. We want to acknowledge and validate, keep a non-judgmental stance. Remember, many of these women may not be in a situation to leave the partner at that point. So this is not our decision to make. You want to assess immediate safety, help establish a safety plan, offer educational resources and referrals, and document the interactions carefully, as we've discussed. And you want to provide ongoing support if they're seen subsequently. So this is a table which kind of shows how we can incorporate the TIC principles into this kind of an interaction. I won't read all of it. So all the kind of interventions are listed here. So back to our patient. So what the course that followed was that, we were able to engage her, and she reported, not surprisingly, history of childhood sexual abuse, chronic depression, anxiety, multiple self-harm attempts, psychogenic seizures, struggle with bulimia, and chronic pelvic pain. We've all seen these kind of patients. And she also had a long history of alcohol use disorder. Recently, she had started using opiates to cope with the emotional pain. And when she had gone to collect the drugs, that's when she suffered the sexual assault that brought her in. So unfortunately, IPV and sexual assault go together a lot. So the patient, after much coaxing, agreed to a SANE exam. She was going through opiate withdrawal. We offered her the withdrawal treatment, trauma-focused therapy, and SSRI. But unfortunately, she left against medical advice. The EG monitoring did show that these spells were psychogenic, non-epileptic. So unfortunately, these are the patients. These are they go through a lot. So let's take a question here. So just to see who's awake here. So U.S. Preventive Services Task Force recommendation regarding IPV screening is, the choices are listed. Anybody wants to take a guess? Option. So the answer is B, screen all reproductive age women for IPV. All right, so my take-home message and best practice message here, that these are very common. So please screen. And we need to know the risk factors. We need to know how to screen for sexual trauma and IPV and how to safely respond to it. A survivor-centered, trauma-informed approach is a must. We want to adhere to the medical and legal standards for evidence collection and documentation. And a best practice recommendation is that all survivors of sexual assault with negative pregnancy tests should be offered emergency contraception and treatment of sexually transmitted diseases. And I'll end with a call to action. So let's all work towards increasing awareness of violence against women, building service lines for IP survivors, advocacy for women's civil rights, promoting social and economic empowerment of women and girls, and promoting gender equality in our communities. So here are some resources and my references, and I'll stop here and I'll turn it over to Dr. Fonseca. Thank you all.
There we go. Good afternoon, everyone. I'll be talking about minority stress and medical trauma. I do not have any financial disclosures to report. The goals will be to articulate concepts of minority stress and medical mistrust. And at the end of my talk, I want you to be able to recall at least one historic contributor to these concepts and describe 3 ways to address these phenomena as they emerge in the clinical context. Some of you who were at the previous talk that I gave at this conference might be familiar with some of these concepts from that talk, but a refresher, and then for the rest of you, I'll be sharing them here too. 2 caveats, just a note on language. I will use the term queer. I'm not using this as a derogatory term. Just as I'm a member of the community, I'm going to use this as a reclaimed word for like an umbrella term for individuals belonging to the LGBTQIA2S plus community. And I will also not be going over depressing statistics from substance use to death that show us what we already know, that there are disparities in healthcare that dramatically impact outcomes for patients belonging to minoritized groups. But I'm hoping that after this talk, we will be able to meet these goals. Just a quick poll. Before this presentation, what was your familiarity with trauma-informed care? So just a quick show of hands. No work with trauma-informed approaches. Okay. Some understanding of trauma-informed principles and models. Okay. And then regular practice of trauma-informed approaches. Okay. So we have a nice blend here. And we know that there are many reasons for this discrepancy in healthcare outcomes, but we also need to consider historic overpathologization of certain groups. And we know that trauma and stress can increase risk for these psychiatric and non-psychiatric medical conditions. and that we need to take a whole person approach. I have this in every talk. This is what I'm talking about when I say whole person, biopsychosocial, all aspects of that, anatomical, physiological, thoughts, emotions, behaviors, economic, environmental, cultural, spiritual, etc. And if we're able to do that, that would be great. We talk about different ways of looking at a person, different dimensions to your identity, different ways to conceptualize a person. But the reality of it is that different aspects of identity do intersect and interact with each other. And these concepts were created by legal scholar and social justice advocate Kimberly Crenshaw, who first talked about Black women facing intersecting forms of discrimination based on race and gender. The interconnected nature of social categorizations such as race, class, gender, as they apply to a given individual or group, and then considering them as being overlapping and interdependent systems of discrimination or disadvantage or privilege and advantage, and that these systems all are interconnected and reinforcing for one another. Also wanted to touch on the concept of cultural humility created by Drs. Melanie Turvalon and John Murray Garcia, who pointed out that this idea that we have of cultural competence can really be a pitfall because we narrowly define it as some sort of mastery of this like limited, finite body of knowledge, when really it's a commitment to engage lifelong learning, self-evaluation, self-critique, and also to redressing power imbalances within all of our relationships, clinical and non-clinical. And even within the clinical setting, how do we interact with our colleagues? And moving beyond that to developing mutually beneficial relationships with communities. So talking about minority stress describes high levels of stress faced by members of stigmatized minority groups. And on a background of generally being alive in an environment, you have this historic context, social roles and expectations, legal threats as a result of disadvantaged or minoritized status, general stressors like housing issues, a pandemic, financial loss. And then you have the minority stress processes, which are either external or distal, like discrimination, violence, structural stigma, or internal as a part of self-identification and a result of internalized processes like, for example, internalized racism, gender dysphoria, things like that. And then these effects are moderated by positive, supportive coping skills, familial support, culture-bound social connectedness. And then all of this coming together impacts the health outcomes. So like we talked about with the adverse childhood events and the benevolent childhood events, you have positives and negatives to having minoritized status. And that's something to think about too when you're working with your patients, that yes, they do have all of these limitations, but they might also have a lot of strengths that may not be acknowledged in the room. And these stresses can be compounding based on intersectional identities as well. And that's why you see, for example, Black men who are gay being less trusting of treatments like PrEP. So you might be called in as the Consultation-Liaison Psychiatry for capacity evaluation, but this is something that I want you to have in the back of your mind. So we talked about SAMHSA. So they define trauma as an event, a series of events or set of circumstances that is experienced as physically or emotionally harmful or life-threatening that has long-lasting adverse effects. So a reminder for all of us working, especially for those working inpatient, that you might go into work and it's an ordinary day for you, but our Freudian slip. Our patients are in the hospital and they're hospitalized. Just going through that brings up very existential feelings for them. And they can experience those moments as being life-threatening. So we also know that trauma, like benevolent and adverse childhood experiences, like minority stressors and strengths, trauma can be compounding. So it's going to be multifactorial depending on the various intersections and the various experiences that your patients have. So patients who have had multiple traumas tend to fare less well than those with a single experience of trauma. And it's like an intersectionality of trauma. So similarly, when we talk about minority stress, I want us to think of minority trauma too, which is trauma experienced as a result of minoritized status. So this can be, again, based on race, gender, age, nationality, class, sexual orientation, ability, religion, etc. Due to time constraints, I will focus primarily on race and gender/sexual orientation, as that's the area within which there is the largest amount of research that's published, which again is problematic for the other less addressed intersections of minoritization. So racial trauma. Any individual that has experienced an emotionally painful, sudden, uncontrollable racist encounter is at risk of suffering from race-based traumatic stress injury. And these experiences can have detrimental psychological impacts on individuals, on communities. And in some folks, prolonged incidents of racism can lead to symptoms very similar to those experienced within PTSD, and in some cases would end up meeting full criteria. So you have, let me see, nothing's showing up there. Okay, there we go. So we have different types of racism. You have the direct racism, which is like the direct traumatic impacts of working within a society of structural racism, being on the receiving end of individual racist attacks. You also have the systemic attacks, and then the different types of stressors here, which are, like I mentioned, direct traumatic. They can also be vicarious or indirect, which can be often associated with epigenetic changes. And we know that trauma can be passed down through the years and then transmitted as well, transferred from one generation to the next. And this can be from historically racist experiences for the community at large, but also personal traumas that are passed down within families, within communities. But in general, and even for those working in the outpatient setting, we need to know about medical trauma. And this refers to the emotional and physical responses to injuries, serious illness, medical procedures, treatments, and interactions with healthcare professionals. It doesn't necessarily require meeting criteria for PTSD, but it does have wide-ranging, long-lasting negative impacts in various aspects of someone's life. And it can occur, again, it can be one event that's really cardinal, or it could be multiple events, multiple interactions, multiple encounters. We don't have clear criteria for management, but we need to be thinking in a long-term way. So what are the outcomes for some of these patients who might experience medical care as traumatic, or even as medical not being designed for them? So you can have poor psychological well-being, psychological distress. So cognitive responses like thinking or worrying about symptoms, concerns about being, a bad partner, a bad patient, concerns about being perceived as in some way unresponsive. Emotional responses like sadness and guilt. And they're also like a more simmering, insidious way that this can manifest with underutilization of services, poor communication, low adherence to recommendations. And then this builds up to medical mistrust. So mistrust is something like not trusting a doctor or a hospital, and distrust is more of a lingering skepticism. Like, I can't put my finger on why, but both are an issue with huge consequences. And we saw this a lot during the pandemic too, with hesitation about vaccination. And we also see it in our patients when we recommend interventions, even when they don't have paranoia. So I like to think about the patient walking into the room, bringing their story with them, and you yourself as a clinician walking into the room, bringing your own story and the story of your profession with you. So medical mistrust stems from a legacy of discrimination, and that can often result in a capacity eval consult. So I will share a few examples here about racism within medicine, primarily from these books, but there are multiple sources focusing on examples in the US for Black individuals. So James Marion Sims, the father of gynecology, in 1844, he performed experiments on enslaved women in Montgomery, Alabama, including Anarcha, Lucy, and Betsy, who were denied the agency to consent because they were enslaved. And so he leased them from their master for the purpose of gynecological experimentation. He wanted to be the first guy to repair vesico-vaginal fistulae, and he performed over 30 surgeries as experiments on Anarcha alone without anesthesia. And he claimed that the procedures were not painful enough to justify the trouble and risk of providing anesthesia. But when he perfected the surgery, he always administered anesthesia. And this was when he performed it on white women a few years later. He also used the bodies of Black babies for tetanus experiments. He thought that the cause was a result of movement of the skull bones during birth. And in order to test this theory, he would take these babies and using shoemakers' instruments, open their skulls based on this belief, he thought that their brains grew faster than the brains of white babies and their skulls were preventing their brains from growing or developing appropriately. And of course, a lot of these babies died, but then he blamed their deaths on their lack of intelligence. It's really contradictory, you know, enslaved Black people, especially Black women, their medical experience really produced this invaluable foundational knowledge for white doctors, but they were continually relegated to the realm of being subhuman or being of service and inferior, flawed, culpable. And we should know that this isn't just in the past. Sims's statue is currently today on the Alabama State Capitol grounds. We also have experiments towards the end of World War II with the Manhattan Project scientists performing radiation experiments on multiple individuals. And the story of Eb Cade, who was on his way to work at a construction site when he got into an accident in 1945, presented with multiple fractures. And the notes say he was a well-developed, well-nourished, colored male, that was their language, suitable for experimentation. They left his fractures untreated for 20 days until after the plutonium injections began, without his assent, without his knowledge. And then in order to test the migration of this plutonium through his body, they extracted 15 of his teeth and took bone samples. And he was noted to have, according to one account, departed AMA from the hospital. And later it was learned that he moved to North Carolina and passed away of heart failure. There are multiple experiences and experiments like this that have been conducted. We all know about the Tuskegee study. I won't go into this in detail, but we know about the untreated syphilis that was carried out. And there are so many more examples. There's like the coercive sterilization of Native American and Puerto Rican women, theft of organs like Bruce Tucker's heart, oral contraceptive trials on Puerto Rican individuals without their consent, lobotomies on Black children at the age of 6 in the 60s, grave robbery for medical research and studies, primarily done on graves of people of color, the use of Henrietta Lacks's cells, Sarah Baartman, Nazi experimentation, and the modern day untreatment of pain or undertreatment of pain. And a lot of patients may not know the details of these events that occurred, but they know what could be happening to them. There's a general sense within the community. And there's also the flip side of that, where they don't see themselves represented in the clinicians, or we don't have that data and the research that supports them. So what about the queers? Heteronormativity and cisnormativity is kind of like the assumption that someone is cisgender, someone is heterosexual. And again, like with other isms, there are multiple negative impacts from this. I'm going to just skip through this in the interest of time. But, you know, we have the history of conversion attempts. We have the history of the sissy boy experiments in the 70s, funded by the NIH, where, you know, folks passed away, unfortunately, from as a result of those treatments that were carried out years ago. And trans broken arm syndrome, thinking about people just based on one facet of their identity, and it's just not for trans people. This happens, say, for example, you know, so as a clinician, do you think of people of color as angry? And why might this be? Or do you think of older patients as being asexual? And why might this be? And do you think of women and femmes as being overdramatic? And why might this be? These misattributions of unrelated clinical problems to someone's identity. And of course, we have done so much harm for the trans and gender diverse community, for the queer community. We didn't even have time during this presentation to touch on aspects of disability, class, even fatness, like Blackness and femaleness is a dimension of social inequality, and stigmatizing interactions for fat women specifically result in them delaying medical care because of that stigma. And again, I'm using the term fat because it has been used by the community. It is not a negative term. And again, for folks, this is compounding with other marginalized identities. So just some food for thought. Our system is not broken. We think it's broken, but it's actually functioning exactly how it was designed to function, and it's serving exactly whom it was designed to serve. And it's on us to be a part of restructuring it and improving it so that we're not complicit in the harm it has caused and continues to cause. There are many techniques and interventions to address stigma, discrimination, improve health outcomes, but all of them will fail without understanding the root causes of oppression. And we need to be taking on the responsibility to earn the trust of our patients and change the narrative of healthcare. Developing awareness of microaggressions and intersectionality is key. Cultivating that cultural humility we talked about, and then asking yourself, where am I in my own cultural identity development process? Where's my patient in that process? What is going on in today's world that might play out in the room? That could be traumatic as well. What is the patient's history with seeking medical care? What experiences have they had? How do these concepts affect transference and countertransference, and even cultural transference and cultural countertransference? And what unique knowledge can the patient contribute to my clinical understanding of them and what's going on? And then how can I provide a safe space for them to share that? Am I practicing shared decision-making and trauma-informed care? And then knowing your limitations and your patient's strengths, but also, knowing your strengths and bringing that into the room too, like apart from your medical expertise, what other knowledge do you have that you can bring to the encounter to support this patient? Be a part of pushing our profession forward rather than a part of a problematic history. And it's not just about our patients, it's about all of us together. That's what I have. I am going to hand it over to Dr. Dragonetti. Before I do, we've been talking about some really heavy topics today. So just a quick pause so we can all take 3 deep breaths together, and then I will step away. Okay. In, out. In, out. In, and out. Thank you.
All right, excellent. Thank you, Dr. Fonseca. So good morning, everybody. My name is Joe Dragonetti, and I hope to sort of take what we've covered so far and begin to apply this, talk about where the rubber really meets the road as far as keeping these trauma-informed care principles in mind and applying them to the care of our patients. I have no disclosures. The objectives for my section will be to describe common consideration for treating inpatients with pre-existing PTSD, reviewing the epidemiology, impact, and phenomenology of medical trauma in inpatients, and then understanding how trauma-informed care applies to the care of individual patients and populations. And so, important point being that these first 2 bullets are different groups. So there's pre-existing PTSD that people come into the hospital with, and then there's also medical trauma that may be, pre-hospital, in the hospital, developing PTSD from some type of medical cause. And so Dr. Nichols already presented this excellent diagram. I really like it. I think it gives us some pretty pictures, some good reminders. It seems like a lot of folks here are already familiar with some amount of trauma-informed care. And so, I would encourage you, if you want to increase your application of this practice, you can find something simple like this and put it up easily in your work environment. You know a lot of the, how to apply a lot of the finer details, but this can just be a nice, easy graphic reminder of the things to keep in mind. And so I want to start with sort of a little case series talking about inpatients with pre-existing PTSD. And so we know that being hospitalized is not pleasant. And this is from a specific study that surveyed veterans about their experiences, veterans with PTSD about their experiences in the hospital. And so nearly half of the patients anticipated discomfort from distressing symptoms, distressing experiences, and items commonly inducing discomfort, hyperarousal, things like noises, being awoken, crowds, approach from behind, change in sleep routine, and that kind of goes on and on. And so what conclusions did they come to when they asked these patients what they would prefer, how they would like to be treated, how they would like things to change? So some of the suggestions were for improvement were leave the door open or close the door completely, leave the lights on, keep the lights off, right? So I just kind of point this out to say that, you know, interventions need to be individualized, right? And clearly some are quite contradictory to each other among different people. Other things that came up, things like medication schedules, knocking before entering, minimizing crowds, improving nurse awareness of the PTSD diagnosis and individual patient preferences, sleep routines, things like that. And so all those things can have implications for how we approach patients and change our interactions with them. And so just trying to imagine the inpatient experience, especially for somebody with pre-existing PTSD, I think it can be somewhat like this. And so they're going to come in with whatever their premorbid psychiatric history is. They are coming into the hospital because they have an acute medical illness. This is a new and stressful environment, right? A lot of doctors in here, we all really like to be in control. I imagine most of us hate being the patient, right? And we're still very familiar with the medical environment, but we know it's not fun. And so they also are being bombarded from inside with their own distressing thoughts. They're meeting a lot of new people that they're not sure they can trust, and they're feeling that loss of control. And so this may be a default that people come in with, a very common experience. And so with our trauma-informed care, I would hope that we can start to shift it to something a little bit more manageable, essentially. So they're going to come in with their predisposing factors. We can't control those, all right, but we can certainly acknowledge them. And then there's going to be environmental factors, psychological factors. But if we can pair ourselves with the patient, we can help address those and maybe make their impact a little bit less. And then by, you know, not being one of sort of the sources of assault, but being an ally, you know, hopefully the care team can be, you know, a person or a group of people that the patient is learning to trust. And so just sort of a shift that we can begin to work towards. And this is, you know, sort of one of the end goals of trauma-informed care is we can begin to subtly and sometimes majorly alter the patient's experience. So that was focusing on patients with pre-existing PTSD. Now we'll shift and talk a little bit about medical trauma. And so patients are admitted to the hospital because they're very sick, often with threat to life, right? So that, you know, is approximating our definition of trauma already. And then, especially if we look at like critical care, many ICUs are defined by the patient's most recent trauma, whether it be a cardiac event, a neurologic event, a burn, a trauma, that sort of thing. And so we do actually acknowledge these traumas, right? In one sense, we describe them, but we don't always, we may look at the burn or the broken bone or the stroke symptoms. You know, our role is often in helping the patient, the team, understand, acknowledge, process the psychological impact of all of these. And so then to look at just a little bit of epidemiology of medical PTSD, this is from actually the ACLP monograph on PTSD. So just sort of summarizing some studies of what we know. Cardiac events have variable rates of PTSD, but, you know, maybe up to a third. Heart attacks specifically have more solid data, around a third. Cardiac surgery, internal defibrillators, and then there's also lots of different factors that go into this. And so for a lot of the cardiac events, it's actually often more important the symptoms the patient experience as opposed to the ultimate diagnosis. So did they have a myocardial infarction or did they just have some angina? It may not matter for the patient's experience of trauma. And then some things they've looked at as possible predictors of PTSD, fear of progression, inflammatory markers, and then with ICDs, the number of firings can yield a higher risk of PTSD. Here's just some more epidemiologic data. So longer ICU stay leads to a higher risk of PTSD. Some other commonly associated conditions that we will not harp on for the sake of time. So I'm curious, I wanted to talk a little bit about the enduring somatic threat model, which is sort of a conceptualization of medical trauma. Who here has heard of this model before? Anybody? All right, so not too many people. And so really this gives us a basis for understanding that medical PTSD can be a very distinct entity from other types of traditional PTSD, right? Where there's an external threat that is often happens and then is resolved. So whereas medical event is a somatic internal source, and usually once something bad has happened medically, that risk does not just go away. I mean, that applies to a lot of people, right? They go back to a dangerous environment. But, you know, for people with medical events, they're basically walking around in that dangerous environment. And so many of the differences here, intrusions are future oriented. Is it going to happen again? Avoidance is very difficult, hard to avoid your own body. And then very keyed to sort of internal sensations. And so a lot of this actually starts, if you look into it, it starts to raise the question, is medical PTSD a completely different entity? And so I think it's very interesting to think about. PTSD is not always the most appropriate diagnosis, so just acknowledging that people's experience of trauma can sort of fall under many other diagnostic categories. And then want to just take a few minutes to run through a case that I think illustrates very well a lot of these trauma-informed principles. So Mary is a 55-year-old female with a history of unspecified anxiety, insomnia, type 2 diabetes, and an unspecified clotting disorder. She's on hospital day 21, admitted for recurrent blood clots requiring multiple surgeries, and there's a psychiatry consult for anxiety and excessive pain. And so going through her sort of abbreviated history, 6 months ago, she woke in the ICU, intubated and restrained. This was her index trauma, we'll kind of come to find out. And she was previously healthy before this until she was found to have a saddle pulmonary embolism, which is what led to that hospitalization 6 months ago. And so she's got prominent post-traumatic symptoms, but those are actually not even necessarily her primary complaint. So she's most frustrated by inadequate communication from her care teams, inadequate pain control, lack of definitive diagnosis for her coagulopathy, and then unclear short and long-term surgical plans. She feels like sometimes nurse shows up to wheel her to surgery unexpectedly and feels, you know, complete loss of control and sort of compounds her emotional distress. And so just some more of her history. So as with many people, you know, this wasn't necessarily her first traumatic exposure. Her social history was there, but it was, you know, on the lower side. And so what did we end up recommending for the care of Mary? So things like optimizing pain control. She got a PCA, ended up really improving the pain symptoms, optimizing pharmacotherapy for PTSD and insomnia, and then improving communication was really kind of the biggest, most comprehensive and challenging intervention that we did. So we did some psychoeducation for the team about the diagnosis of PTSD or index trauma. So her index trauma was hospitalization related. She's been in the hospital now for weeks. And so she can't avoid that distressing environment. Talked about some of the patient's concerns. And so we sort of described in terms of her feelings, her perceptions. She feels like she's not being listened to, that sort of thing. So try not to encouraged care team members to use clear plans, repetition of the plan, visiting as a group instead of, you know, just kind of the back to back, one person from this team, one person from that team, another person from the first team, where the information becomes quickly disorienting. And so on the bottom here is kind of a breakdown of some of the teams that were involved in her care, how we kind of phrased some of this education and liaison work with those different teams. And so this is kind of the takeaways from Mary's care. So medical PTSD was not recognized or diagnosed initially. Communication and trust were major issues. Emotional safety was tenuous. And then pain control strategies in particular had implications for trust, collaboration, and patient empowerment. And, you know, I think kind of a lot of that liaison work highlights the role of the psychiatrist as trauma-informed care leader. And so this is that same information broken down to show that trauma-informed care interventions take place at multiple levels. So there was individual level diagnosis and treatment of PTSD. There was team level facilitating communication, liaison work, and then, even beyond that, psychiatrist as trauma-informed care leader, helping influence the system. So the care teams, the nurses, as days and weeks went on, obviously are rotating. And so I think that's very important to understand that, while trauma-informed care does not require a psychiatrist, we're generally going to be most familiar with those principles and can absolutely be a leader in just helping people understand these principles. We don't need to teach them outright to people often, but we can help teach them in a case-by-case basis. How is this one principle, say creating a safe environment, how does it apply to Mary, and how can we facilitate that? So I like this concept here of universal precautions when it comes to trauma-informed care. So again, none of this is really psychiatric care, but just ways to approach a person. And so acknowledging the obvious trauma, acknowledging the possibility of unknown trauma. And then if we think about what Dr. Fonseca just covered, if we have just basic identifying or demographic information about the patient, there's sort of an in-between area in there too, where we know that because of something about their history, their background, their race, whatever it might be, they're going to have a higher likelihood of that unknown trauma that we don't know of. So we need to make sure we ask, don't assume, foster physical and psychological safety, and empower patients providing choices. All right. So with that, I'm going to wrap up so that we can have some time for Q&A and discussion. So thank you very much.
All right, everybody. So I got one question from the chat, but we're also more than happy to hear from any of you guys. Meredith will be ferrying the microphone around so that we can capture the audio and it'll record. So the question I got from the audience was, any thoughts about whether we should embrace the proposed term post-traumatic stress injury? Anybody want to take that one? And take that.
Can comment on that briefly. I mean, I think I've not heard a lot about that, but I know that I often use the term post-traumatic stress without disorder, right? Because a lot of people experience those symptoms, those after effects, without full manifestation of the disorder. And so I often use actually post-traumatic stress syndrome to sort of describe that. Is it PTSD? I'm not quite sure yet, but the effects are there. Dr. Powell.
Great session. It's a really great session. I really learned a lot. We call it PTSS, or post-traumatic symptoms, stress symptoms in childhood. So the one perspective you don't have here is a child psychiatrist in terms of medical trauma. And we now have 500,000 children who have survived childhood cancer who are going to become your patients. So they come to you with a fair number of traumas that they've experienced. And often it was their Wilms tumor at 2 years of age. They don't remember a thing about it. But when their body gets in that hospital, they're going to remember a lot about it. So I just encourage you to really take a serious past surgical history, past medical history, because they don't often even remember. I've had literally patients be like, oh yeah, I had this childhood cancer. And they're like, oh, that explains a lot of things. So you have to dig a little sometimes. So just try to remind you that medical trauma, sickle cell patients who come to you at 35 have had 50 hospitalizations before they got to you, and are quite distrustful of the system, having experienced a lot of discrimination and disparity. So I just point that out. And in your last case, this patient lost a child to SIDS. That's not a small little trauma in the background. So I just would say that, and you had abusive relationships, abusive other experiences. So I guess my question is, did you rope in social work for the aftercare? Your work is correctly says, we don't want to unpack all that and necessarily in this hospitalization, but again, it's something that would have to be addressed moving forward as part of like in the first is all the wraparound care that has to happen even if we don't do it in the hospital. But thank you. Yeah.
I think that's a really good point. Thank you for bringing that perspective in.
I was just going to add, as a child psychiatrist, I think that that's so critical. So thank you so much for highlighting it.
My question's for you. I wonder if you could comment on the utility of using ACEs self-report as a measure for universal CL or as a universal screening for proactive CL to target your interventions.
That's a really interesting idea and question. I haven't seen it used in proactive models, though that really isn't an area of expertise of mine. I think it's interesting to think about, just given that we know the impact that ACEs have. I would say, I think it would also be important to think about those benevolent childhood experiences because they provide some protection. So I think it's interesting. I'm not aware of literature out there about it.
Great research. Every patient who walks in gets an ACEs score and a benevolent childhood experience the scale. So we have that as a background.
So for those of you who are joining virtually, Dr. Sachdeva said that it would be interesting to have a study where we were looking at everyone who walked into the hospital getting an ACEs and benevolent childhood experiences score. Thank you for the question.
My question's for Dr. Fonseca. When we look at Carl Bell's work, well, and it's kind of for all of you, but mostly Dr. Fonseca, when we look at Carl Bell's work and some of the work on child abuse, we know that there's bias. There's bias in CPS. There's bias in the general population. And at some level, I always find the ACEs a little bit biased because lack of food often is due to poverty. And is that really, should we in the considering like the benevolent childhood scores, should we really always consider that an ACE, right? Those sorts of things. So I just wanted to you to comment on that and like how are we looking at that in terms of our minority populations, but also in terms of our white populations. Are we underdiagnosing this? Are we underdiagnosing trauma, IPV, which might look differently? I once had a patient say, women of color call the police, white women go shopping, and they may be less likely to disclose. So additionally, men, when we look at asking the IPV questions, they should be asked of everybody, not just, women of childbearing age. Older women, often are in IPV relationships that have been going on for years, 40, 50 years. And their husband doesn't hit them as often now. So just a comment on that.
So start by saying that that's a lot. I'm not sure where to begin in addressing that. And I'll start by saying that I'm not a child psychiatrist, so I can't really speak as well to some of those aspects and would defer to my colleagues here. But something that came to mind when I heard you talking was kind of, where does the responsibility lie? Like, is a responsibility on us as clinicians to kind of tailor care to individual patients? Yes. Is a responsibility with the person who caused the trauma. Is like when you mentioned the ACEs and the poverty, for example, like, are we saying that the parents are abusive, or are we saying that this is a signifier of a larger problem? And I think the responsibility really lies with all of us, with society as a whole, and that needs to change. And it's really hard when we think about each individual case and all the different intersections, but we're called to do that. That is our work. We're called to tailor care to our patients. And yeah, I think something that we didn't talk about too, that I'm just going to go off on a tangent for a second here, Our teams are made up of all kinds of people. And just because someone looks one way, you cannot assume that they haven't had intersections in their identity, that they haven't had ACEs that they themselves have been through. And as leaders of trauma-informed care, as Dr. Dragonetti was saying, as CL psychiatrists, it's on us to also check in with our teams and make sure that as we're providing trauma-informed care, their teams are doing okay. And what do they need from us, and what do we need from them, so that we can work together to support our patients in the best way possible in all of their intersectional complexities.
Sorry, go ahead.
I have a follow-up comment on what you just said. Definitely, it's not only women that go through IPV, both men and women. It's just disproportionately higher in women. So, and my topic was trauma in women, so we focused on that. And as far as screening, it's definitely we want to screen everyone. The recommendation from the US Preventive Services Task Force can screen all reproductive women, but there's literature to show that IPV is as common and as impairing for older women. So we don't want to leave them out. That's just the official recommendation, if that addresses your question.
It's also really It's also really common within queer communities, intimate partner violence, and not often talked about too.
I just wanted to add that concern has been brought up, and that the benevolent childhood experiences scale has been studied across races and SES status for this very purpose, so that it was culturally informed. And I couldn't agree more with what Dr. Fonseca said about the responsibility, and that's really what those CDC recommendations are sort of around, that it's on all of us, that we have the opportunity to make a difference.
So unfortunately, we're at time, but thank you guys so much for all the great questions and for coming.